Without further ado, I'll go ahead and turn it over to Michael. So, thank you all again for joining.
Great. Thank you so much. Everyone, welcome. We're going to spend the next hour or so talking about sex and drugs. So thank you for taking the time to join us today. Let me introduce myself first and then move into the presentation. So my name is Michael Vigorito. I use he, him pronouns. I'm a licensed marriage and family therapist, author, and consultant. I'm in private practice in DC, where I primarily work with men concerned about problematic or out of control sexual behavior, where I run a couple groups that are kind of general for heterosexual, gay, bisexual men presenting with that concern. And then I have a group that is more specific to gay and bisexual men concerned about maintaining their sexual health and recovery from meth addiction. Some of this presentation will be pulled. We'll be pulling information from the book that I co-wrote, Treating Out of Control Sexual Behavior, Rethinking Sex Addiction. And I'm affiliated with University of Maryland and their Prevention Research Center, which provides capacity building training for behavioral health organizations and providers to integrate sexual health into routine care, but also to provide LGBTQ plus affirmative practices. I'm excited to be one. Thank you for the invitation to be here. I really appreciate it. This is a topic that I think is very important. And I'm excited to be here to talk to you for the next hour or so about sex-related drug use. This topic has the potential to generate some significant discomfort as it connects to two stigmatized behaviors, drug use and sex. I don't want to start this training as I've seen others on this topic do with what I consider like anecdotes or kind of salacious examples of sex-related drug use that highlight the dangers of pairing sex with drugs or that communicate a moral disapproval of behavior. Of course, people experience negative consequences for this behavior and have difficulty stopping. But as in therapy, I find it's more helpful to speak from a position of destigmatizing these behaviors, because these behaviors may be more common than you realize. And shame about sexual experiences is more likely to create distress and fuel maladaptive coping than it is to help folks move toward health and happiness. So my objective today is to help you provide effective care. So the most effective strategies I have found when working with this issue is involves interventions that honor client autonomy, that establishes a welcoming therapeutic relationship. So together, you and your clients can be curious about the functions of the behavior. And it's difficult to do that if we stigmatize these behaviors. So pay attention to your reactions to the discussions about sex and drug use. Identify any negative judgments, any assumptions that you carry, or any potential countertransference as a part of the preparation needed to facilitate sexual health conversations and motivate change with your clients. All right, so why don't we get started here? I'm going to launch. Get started here. All right. Get that out of the way. So I titled this presentation Liberated Spaces, and that hopefully will become obvious in a moment and why I titled that, and talking about pairing sex with drugs. So it's important to contextualize sex-related drug use within the overall picture of substance use prevalence rates. So it's difficult to understand how common or frequent sex-related drug use is if we don't have anything to compare it to. So I pulled numbers from the 2020 National Survey on Drug Use and Health to kind of give us some grounding here. For those who are unfamiliar with the survey, it's a comprehensive household interview survey of substance use disorders, mental health, and the receipt of treatment services for these disorders in the US. It's gathered and published by SAMHSA. It samples all 50 states plus the District of Columbia. I have included numbers around the general population. I've also pulled some of the numbers and highlighted numbers for lesbian, gay, and bisexual folks, because as you're going to see later, when we're talking about prevalence rates of pairing sex and drugs, LGBTQ folks have a higher rate of pairing sex with drugs than the general population or their heterosexual and cisgender peers. But you also notice there are no numbers about transgender, non-binary folks that come out of the survey. I'll include some of those later. So this prevalence rates is just looking at illicit drug use in the past year among people ages 18 and older from the 2020 survey. The 2022-23 numbers have come out, but this is the numbers that I had available to me at the moment. And you can start to see the differences. Well, one, you can start to see the prevalence rates in general, but also differences between these populations. And you can also start to see the drugs that are more common than others, marijuana being the first. The psychotherapeutic drugs, these include prescription stimulants, tranquilizers, sedatives, and pain relievers. Alcohol use given in the past year in the US usually ranges 60 to 65%. I pulled some of these numbers that take a look at both young adults and older adults, looking at their past alcohol use, or their use in the past month, but also people who are reporting having an alcohol use disorder in the past year. So the rates are slightly higher among LGB folks than the general population. And you also might notice that the rate of people reporting that they drank in the past month goes up slightly between young adults and older adults. But interesting, the rate of alcohol use disorders goes down when comparing young adults to older adults. And then looking at people's ages 18 and older with a substance use disorder in the past year, first taking a look at the number that about 15% of the general population reported having a substance use disorder in the past year. That almost doubles when we're talking about LGB folks. And then you can see the rates of people who are struggling with alcohol, struggling with illicit drugs, or struggling with both. And as I mentioned, those numbers didn't include numbers looking at transgender or non-binary populations. They pulled some studies just so you can also include those numbers in this discussion. So this first lit review has found that substance use disorders were found to be significantly higher in transgender populations when compared to cisgender populations. Transgender men appear to be higher risk than transgender women for most substance use disorders. However, transgender women appear to be uniquely susceptible to methamphetamine use as well as injection drug use. I pulled that information just because meth is a common drug that people pair with sex. So even though you might see transgender men having a higher risk than transgender women for substance use disorders, the one that was paired with sex seemed to be having a higher risk among transgender women. And then the meta-analysis at the bottom, when compared to cisgender people, transgender individuals were at a high risk of tobacco and substance use disorders, but didn't differ in terms of alcohol use or alcohol use disorders. However, were more likely to use cocaine, amphetamines, and 3 times more likely to use inhalants, which is another drug that's commonly paired with sex. So here I kind of messed up a little bit because this is kind of sometimes point in the presentation where I'll ask the audience is like, so what do you all think are the drugs that are or substances that are most used during sex? And then ask you to put it in the chat and we talk and challenge our assumptions, what we thought. But I forwarded the slides beforehand and I forgot to take these out. So I think everyone has access to these answers. So isn't that a fun quiz if people kind of know already what the answers are? So we're just going to go through it and you can hopefully see the magic of my slide presentation order. But this will obviously not be a big question because you already have the answers. So the substances most used during sex: alcohol, cannabis, and MDMA. The 4th most used substances, and I should also indicate this beforehand, this study was looking at the 2013 Global Drug Survey. This survey was pulling information or gathering information from locations like the UK, Australia, the US, Eurozone, and Canada. So before we're looking at national rates, it's hard to find prevalence rates on how people pair sex with drugs. So this is the one I found was looking more at a global. So some of that, the prevalence rate might be a little bit different than we would anticipate for just the US only. But and the reason I say that is because of what these answers are going to be next. So what the 4th most used substances for everyone except for gay men was cocaine. And for gay men, it was poppers. Now, I say it's a bit potentially surprising, but one of the things you might think was like, well, one, people may have the assumption that the 4th most used substance for gay men would have been methamphetamine. But if you notice from that previous study how low on the list of people who are using methamphetamine is compared to inhalants, and because of the length of the high for methamphetamine and the ease of access of getting poppers, I was actually surprised that this was lower and not higher. But because this is a global survey, poppers is actually more difficult to get in other countries than it is to get in the US. So some of these numbers might be actually a little bit surprising to folks to what the prevalence rate might be in the US versus in some of these other countries. All right, so now we're talking about trying to understand the prevalence rates of how people connect sex with drugs. So again, as I mentioned, the prevalence rate on this issue is difficult to ascertain, and we are limited to the data that is out there. I found this one survey that was looking at women who have sex with women in the UK. This was, get to my notes here, based on the LGBT lifestyle, sex and lifestyle survey. That was a cross-sectional online questionnaire aimed at LGBTQ folks in the UK, and about 1,500 women who have sex with women were included in this analysis. Among that population of folks who participated, 94% indicated they drank alcohol in the past 12 months, 67% of which had sex under the influence. Of the 39% who said they took a drug in the past 12 months, of those folks, 44% indicated that they engaged in sexual activity. Interestingly, there were no reports of meth use in that population. And after alcohol, the most common drug that was paired with sex was cannabis, right? So if you think about the prevalence rates that we talked about before, cannabis being the drug that most people took in the past 12 months, this kind of tracks with that information. And then again, pulling information that involved transgender non-binary folks. In the Santos article, they found that about 50% reported being under the influence of any substance or alcohol during, before or during anal intercourse in the past 12 months. You can notice in the difference in this survey compared to the National Drug Use and Health Survey. Pot was the most frequently used illicit drug in the National Survey of Drug Use, about 18% of the general population, about 41% of the LGBT population. And so here was also the highest used drug, but then there's some switching, right? Meth was one of the least used drugs in the National Survey of Drug Use. That was like about 0.3% of the general population and 0.8% of LGBT folks, where here it was the second most used drug at approximately 20%. And alcohol use was roughly the same. Now, I often see presentations on sex-related drug use that only focus on folks who are engaging in chemsex. I'm going to define that term in a second. And I worry that just focusing on this group dismisses the regularity with which people pair sex with drugs. And I worry it contributes to the stereotype of gay and bisexual men as being hypersexual, right? So it's one of the reasons why I started with just talking about let's get the picture of drug use as a whole and start to see if we can understand the prevalence rate where everyone potentially has, where everyone's included in discussion of pairing sex with drugs before we then start to highlight some subgroups, right? So one of the subgroups I think is important to talk about are those who are engaging in chemsex. So there was a systematic lit review that I thought was important that was trying to take a look at the prevalence rate among gay and bisexual folks to see how frequently are they pairing sex with drugs. But first, let me define chemsex, right? There's no universally accepted definition of chemsex, right? The Maxwell definition was the use of drugs before or during planned sexual events to facilitate, enhance, prolong, and sustain the experience. That term typically comes out of the UK. In the US, we have often described it as party and play, P&P. So the term was typically used by a subgroup of gay men. And the term chems in the phrase chemsex was the truncated word of chemical, interchem, from commonly used nickname on text messaging or messaging apps or web apps. It originally referred to drugs such as meth, GHB, or methadone, which is bath salts or synthetic stimulant. Other substances might be involved, such as alcohol or Viagra or ketamine, cocaine, poppers, but they aren't typically the high that gay and bisexual men are pursuing in these areas. So this review included research from the US, Canada, and Europe. So you can start to see the prevalence rates were really dependent on the sampled population of men who have sex with men. So the non-injecting prevalence rate ranged from 3 to about 30%, but samples from sexual health clinics ranged over 15. So when you just pulled out the samples that were just looking at sexual health clinics, which is a bit of a skewed sample of the MSM population, the prevalence rate was around 3 to 15%. And then an injecting prevalence rate ranged from like 1% to 50%, but the larger samples ranged from about 1 to 9% of the population, right? And then lastly, I pulled information or data that I found that was looking at Dutch swingers. I know it sounds pretty, a bit too specific for our intents and purposes here. However, I wanted to find information, again, that was looking at folks, and not one, I'm always a bit concerned about over stigmatizing or stereotyping gay and bisexual folks. So I was trying to find other populations that maybe were living in a heterosexual context who engage in ethical non-monogamy, who might be similar to a gay male population, but who might prioritize sexual experiences similarly, who've created communities around sex. And what are they reporting around their use of sex while use of drugs while having sex? So in this survey, they found I found of Dutch swingers, about 1,000 people participated. 44% reported they were using drugs during sex in the last 6 months, and of which half of them were women, 40%, 44% were bi men, 39% were heterosexual men. And you can see the list of drugs that they were commonly pairing with sex. For them, MDMA, GHB, laughing acids like whippets, but also cannabis and poppers. They didn't ask the two-pronged question about gender or about bi women, which was an interesting way that they were gathering data on their population. And they did exclude alcohol or erectile dysfunction medication. So those are not included in the data. And then lastly, I was trying to find, like, if you notice, I kind of started out broadly. I was like, who uses drugs? What's the prevalence rates of drinking? And now I'm trying to get more specific around pairing sex with drugs. And now I'm getting more specific with people who have substance use disorders and the impact on their sexual health or their sexual activity. So I pulled these two studies that was looking at people who were seeking treatment or presenting for treatment regarding substance use disorders and their sexual expression. So this first study was just looking at 180 patients presenting for substance use treatment. All of them reported changes in their sexual functioning due to their primary use. Over 50%, and about half, reported either enhancements or decrements. Quarter of them indicated that their sexual thoughts and feelings and behaviors were often associated with their primary use. And then 10% approximately experienced difficulties decoupling their drug use from their sexual behavior, or they thought their sexual thoughts and feelings generated cravings, or felt that they needed treatment for their sexual behaviors. And then the last one was looking at a group of heterosexual men presenting for substance use treatment. About 3/4 of them endorsed having sex under the influence in the past 90 days. And over 1/3 of them endorsed sex under the influence during their most recent sexual encounter. And this is part of the evidence that I cite when I'm talking with substance use disorder treatment facilities and encouraging them to be screening for sexual health issues among all of their patients, because it's likely their substance use disorders is having some type of sexual consequence. And I encourage them to have that as a part of the conversation in treatment. All right, so I'm going to pivot here for a quick second and talk to you about the IMB model. I use this both clinically and as a teaching tool, right? It helps organize training content using an evidence-based treatment approach that I'm also inviting you to consider when working with your client, right? So we're thinking about ways to help enhance behavior or create behavior changes that's not just dependent on a diagnosis. Like we have a medical model of assess, diagnose, and treat. Here, I'm thinking about how do we shift and change behavior. So I like this model because I think it's a little more flexible. And this model organizes interventions into 3 different areas, right? It helps us stay aware that knowledge alone rarely changes behavior, and that motivation and skills are important elements to consider when helping folks improve their health with or without a diagnosis. Right? So we have these questions like, what are we trying to influence? What health behavior would we like to change? So behavior change can be anything, right? It could be about improving medication adherence. It could be about smoking cessation, or for the sake of our talk today, engaging in sex without meth, or communicating sexual interests while sober, or not using alone. So information, right? Basic knowledge about the behavior, about a condition or concern that might include, how a disease develops, like an STI, or how it's transmitted, the expected course, the effective strategies for prevention. So in my conversations with my clients, I'm listening for knowledge gaps because I feel like I can be a source of information for folks. So do they have knowledge gaps around the effects of substances on their sexual functioning, or their ability to consent during a sexual encounter, or the risk or how vulnerable they think they are to an STI or HIV infection or an unintended pregnancy? Listening for knowledge gaps around the effects of combining different substances that are associated with chemsex, or the appropriate dose of a substance for the desired effect that they're seeking. Right? So sometimes providing this information will be enough for clients to change their behavior or to reduce harm, to improve their health and happiness. But oftentimes for the clients that I'm seeing, we need more, right? So then I'm looking for motivational interventions. Motivational interventions, or I should say motivation alone, encompasses personal attitudes toward that health behavior change. We're talking here about the one's readiness to change. If you're familiar with the stages of change or the trans-theoretical model for health behavior change, thinking about perceived barriers or social support, all these are connected to motivation. So many of my questions in this area are around, what are the desired effects that they are seeking when pairing sex with drugs? What feels good about it for them, right? You can already start to hear the importance of speaking and asking for some of these details that for some therapists might start to generate some discomfort, because we're going to be really leaning in to the details of what is sexually pleasurable for our clients. So then I'm also going to be listening for, what are the motivations that compete with that behavior change, right? So if they are wanting to discontinue their use of alcohol, right? But then we have these motivations around sex that compete with it, right? They might find that they might have these beliefs that I'm a better sexual partner, or I feel more free when I'm drinking. And now that I'm not drinking, being sexual is really hard. So now we have this competition between their recovery from alcohol and their desire to be sexual, right? And oftentimes what I'm listening for is how their behavior, how the original symptoms were a solution to some bind that they were experiencing, right? A solution to the shame that they had about this sexual desire that they had. And so they were using drugs to disinhibit, which we'll talk more about in a minute. And then behavior skills. And these are just making sure that the client has the specific tools and strategies necessary to perform this behavior that we're encouraging, right? So do they have the communication skills to be able to talk about their sexual desires openly and honestly, or their boundaries clearly and effectively, talking about what they like and what they don't like? Do they know how to reach out when they're sexually triggered, or they feel too embarrassed because the trigger is sexual, right? Or, more fundamental to psychotherapy, have they developed emotional regulation skills that they are lacking because they've been using drugs as a way to regulate their emotions, right? So if we're taking away their primary coping around drugs, do they have the skills to emotionally regulate, right? So the IMB model demonstrates that information is a prerequisite for changing behavior, but itself is insufficient to achieve this change. So often therapists feel more comfortable sharing information about the risks and harms of drug use, and they often feel less comfortable exploring client motivations about sexual pleasure, or developing client skills that promote sexual pleasure and satisfaction. So motivation, behavioral skills are critical and can work independently to influence behavior change, which includes uncomfortable conversations about sexual pleasure. Okay, so then, as I mentioned, I use this also as a teaching tool. So let's talk about some of the kind of informational pieces that could be helpful when trying to promote health and happiness with our clients. I'm looking for, just checking on time. Okay, great. All right. These tips were developed specifically for folks who are actively using in general, but they also contain important information for folks who pair sex with drugs. This comes out of Carl Hart's work. I published a book called Drug Use for Grownups. In particular, it's important to remember, and we're going to get to this piece, that the drug effects alone do not, or say, it's important to remember that drug effects are not determined by pharmacology alone. This is what some things we're going to talk about here. So first, when we're talking about information and knowledge gaps, that can hopefully help people shift their behavior and promote behavior that improves their health and happiness. First things we want to talk about is dose, right? The amount of the drug that is taken. And it's important to remember the dose makes the poison, right? That even water and oxygen is harmful in the wrong dose. And a related issue here is around potency, right? The amount of the drug that's required to produce the desired effect. The smaller amount of the drug that's needed to cause the effect, the more potent the drug is. With experience and with knowledge of what they are taking, people can adjust their dose depending on the effects. It's similar to how people drink vodka differently than they drink the average beer or wine. Vodka has 40% alcohol. The average beer is like 5%, and wine is used about 12%. And with that knowledge and with that experience, most people can self-regulate. Route of administration, right? The speed at which the drug reaches the brain, and therefore the immediacy and intensity of drug effects. The faster the drug gets to the brain, the more immediate and intense the effects will be. Possible routes, swallow, snorting, intravenous, or injecting, right? Inhaling, which could be smoking or huffing, topical, rectal, or vaginal, right? Carl Hart strongly recommends that novices avoid IV use. Rapid onset of drug effects can be achieved by snorting or smoking without the associated risks of injecting. Now, for folks who have been in this field and kind of watching the changing attitudes around hallucinogens or psychedelics, are probably familiar with these next two terms, mindset and setting. This is where we're talking about earlier, right? That drug effects are not determined by pharmacology alone, right? That individual characteristics influence drug effects. Factors that include people's mood, their physiology, to their preconceived notions of that substance or their expectations of the drug. So if someone was taking acid and they had this belief that, oh my God, I'm going to learn, if I take this drug, I think I'm going to believe I can fly and jump off my balcony, which is a lot of the myths that have been perpetuated about LSD. That's going to increase a lot of anxiety for that person, right? And that will influence the drug effect because that's how their body is reacting to what they just did, right? And the drug effects can differ widely on levels of physical fitness, how rested a person is, how nourished they are, right? And in setting, environment influences drug effects as well. This could be both the physical environment and the social environment. For instance, like the effect of psilocybin or someone is taking mushrooms, the effect would be different. The person's kind of casually walking through a concert, or meth taking in a lab for research is going to feel a lot different than meth being taken at a sex party. And let's talk about what some of the common drug effects are on sexual functioning and experiences. I'm going to start with alcohol. Alcohol is the most prevalent substance that people pair with sex. And research suggests that alcohol can at times improve sexual behavior or desire, while other research suggests that can impair sexual functioning. Heavy alcohol use, right? Again, talking about dose, can impair sexual and reproductive functioning and can impair someone's ability to consent. Right? Cannabis, this high can be like an hour to 6 hours, depending on the route of administration. Self-report research indicates that many users find it increases sexual desire, pleasure, and satisfaction, where long-term cannabis use can lower someone's testosterone and other hormone levels and can cause sexual dysfunction. Cocaine, which is more of a stimulant, can be up to 2 hours. People describe themselves as being alert and happy and excited. They have increased energy, some increased self-assertion and increased desire and horniness. They also talk about increased sexual confidence and more confident initiating sex. They talk about kind of the intense pleasure and kind of feeling closer to one's sexual partner, but they also report it can delay orgasm and can contribute to erectile dysfunction. GHB, which is more of a depressant, kind of a 2-hour high, people report it can increase desire for sex and reduces inhibitions. But people also report feeling more relaxed. Because of that relaxation, talk about how it's easier for them to be the receptive anal sex partner in a sex act. They also report it can delay orgasms. Some of the negative effects of GHB could include things like dizziness, weakness, confusion, drowsiness, loss of consciousness, which can impair someone's ability to consent. And with GHB in particular, the dose needs to be precise because it's easy to take too much. And it shouldn't be mixed with things like alcohol, tranquilizers, ketamine, or antihistamines because it can cause respiratory distress or death. Ketamine, which is more of a dissociative anesthetic, 1 to 3 hour high, depending on the route. And people talk about feeling detached. They feel dreamlike, but also feel relaxed and happy. There's a pain relieving quality to ketamine, and people describe it helps them decrease some of their inhibitions. Some of the negative effects here could be confusion, nauseated. People do report an increase of sexual desire. They also report a loss of erection or orgasm. There's there's a pain relieving quality. Now, I don't know if you folks who do any type of reading on these topics, it's always interesting to read how professionals or academics try to publish details around sex. And sometimes they can be really clinical or kind of euphemistic. And so I always like some of the phrases that they come up to describe some of these behaviors. And one of them was in the sentence around the pain relieving qualities makes it easier for folks to have heavier sex. And I was like, heavier sex? I don't know what that means. So trying to find how they were defining heavier sex, and what they were referring to was fisting. Methamphetamine is a stimulant. This can be a high that ranges from 4 to 16 hours, depending on how the person took the drug. In general, amphetamines can enhance sexual pleasure and openness. People talk about how it increases their sense of intimacy, energy, a sense of euphoria, and sexual satisfaction. It also increases one's heart rate, decreases appetite. And amphetamines could include things like Adderall or meth or MDMA. In the short term, people often report they have stronger orgasms, maintaining erections for longer periods of time. But over the long term, people talk about how it can lead to higher risk sexual behaviors. Long-term use can delay or weaken orgasms, decrease libido, cause erectile dysfunction, and fertility issues. Now, MDMA is kind of this drug that's both kind of a stimulant and a psychedelic, 6 to 8 hour high. People report having mild hallucinations and that amphetamine-like qualities, but they also talk about experiences of feeling love and happiness and sexual desire. And people describe having maybe kind of more of an interest in the physical connection rather than the actual intercourse. But also people report a loss of erection and delayed orgasm. And lastly, with poppers, these are kind of a fast-acting, short-lived inhalant. It produces relaxation of smooth muscle, which can be found in the anus sphincter, throat, and vagina. People report that it amplifies sexual pleasure and makes receptive anal intercourse easier, but can also be problematic for people with heart problems because it can cause irregular or fast heart rate. All right. Now, jump here. There's a risk when highlighting sex-related drug use that, as you can hear, I'm worried about, and I've been trying to contextualize this behavior as much as I can. But I worry that people who attend this will internalize that a message that a person's drug use becomes problematic because they've paired it with sex, right? That's not the message, right? A person's sex-related drug use doesn't happen in a vacuum, right? And the reasons that they use might become problematic extends beyond this coupling to all the reasons why substance use becomes problematic in general. So I've included these next 2 slides to highlight how many of the negative effects of drug use, right, are related to the other factors that we are accustomed to, right, when we're talking about general substance abuse treatment, right? First and foremost, the effects of poverty and housing insecurity, right? The physical and psychological consequences of chronic stress related to poverty and housing insecurity contribute to motivations to use or motivation to self-medicate with drugs. The effects of criminalization on drug use leads to supply problems, which means we have an unregulated product on the streets, and there are no consumer protections. And some of these drugs also extend to restriction of consumer drug tests that further limit a person's ability to understand and know what it is that they are taking. And that lack of information can also lead to negative effects alone, but also negative effects of combining drugs, because oftentimes people aren't just using one drug, right? This concept of minority stress, if folks are familiar with working with LGBTQ folks, right? Individuals who identify as sexual and gender minorities are exposed to elevated levels of stress due to LGBTQ plus specific social, interpersonal, internalized stigma. And that excessive stress is constantly present and can be directly or indirectly lead to some of these disproportionate behavioral health consequences or the disproportionate rate of substance use and substance use disorders that we see in this population, right? Also with co-occurring psychiatric conditions, like untreated or undertreated psychiatric conditions might influence the mindset of the person using drugs or might influence their experience. They might be using drugs to self-medicate a psychiatric condition like depression or ADHD, anxiety, bipolar, et cetera. This increases the likelihood of a negative drug experience or may worsen those psychiatric conditions. Other factors that people are probably familiar with, right? Some biological predispositions or genetic factors, their family of origin environment and their family's relationship with drugs and alcohol, their history of adverse childhood experiences and age of first use, all are factors that can contribute to when substance use becomes problematic. So it's important to screen for all these factors that contribute to problematic drug use. And it's important to know when people pair sex with drugs and that we're not overly emphasizing the fact they're connecting with sex, even though it's going to be an important part of their clinical picture to understand either the sexual consequences of it or how they were pairing that moving forward when we're trying to talk about their sexual health plan and what we want that to look like. All right, so what are some of the motivations that people are reporting when they're talking about pairing sex with drugs? Now, I think it's important to play, as you heard, to play substance use in this larger context. And I think Nida did a nice job with summarizing some of the reasons why people just initiate substance use, because I think that's also related to why people choose to pair sex with drugs, right? One is because it's pleasurable. It feels good. It's pleasurable or it feels good is actually one primary reason why people have sex in general as well, when we take a look at the research about people's motivations for sex. This piece, I think there's a model that I think I want to describe here that relates to these first two. Like there's a model called the dual control model of sexual response. And it looks like people's excitatory capacity and their inhibitory capacities. And it's the balance of these two systems that produce sexual response, right? We all have a gas pedal. We all have a brake, right? And the gas pedal is typically around what feels good. That's what moves us forward. And our brake are the things that inhibit us. So the first one is all around the gas pedal. What feels good? What is motivating us? And the second, to feel better or to not feel at all, is talking a little bit more about the brake, right? Sometimes people use drugs or pair sex with drugs to lessen feelings of distress that's related to anxiety or depression. People disinhibit themselves to have the sex that they want to have, right? So if they are experiencing shame about the things that they like, or maybe they have kind of negative body image that makes it really uncomfortable. They become super self-conscious when they're starting to get naked and be sexual. One way to disinhibit themselves from doing that is to be high, right? Oftentimes the stories that I hear from the guys in my mass sex group is they are in search of these liberated spaces that are free from anxiety, that are free from rejection or the fear around rejection, free of shame, that it helps alleviate them in the moment of that negative body image I just mentioned, so they can have the sex that they're like, right? So part of what is motivating them to engage in this chemsex communities because these spaces feel liberated of all of those inhibitors, all the things that are tapping on their brake. But also to do better, right? People use drugs to improve their cognitive ability, which are stimulants, right? Or maybe their athletic ability, like steroids or human growth hormones. Or for this talk, maybe they're using some drugs to improve their sexual functioning. And that could be Viagra or other drugs of that ilk, or poppers, as we talked about some of the poppers or ketamine, some of the pain relieving qualities or the relaxation that creates, so they can play the role of the receptive partner. And I've got clients who talk about the social lubrication of alcohol, right? That to me, when I hear that, is they want to do better, right? They want to improve their social skills, and that becomes a very strong incentive to continue drinking. Right? And then lastly, like curiosity. People are just like, sure, what is this about? I've heard this in the community, or I've read about this, or I saw Euphoria or something. I don't know, something that kind of piques their curiosity. And that is part of the reasons why they might initiate or try to pair it, right? And here, I think community norms can play a role. So if the community that's similar to, let me back up. So some of the community norms that are playing in gay and bisexual men's worlds around chemsex, right? There's just in general, there might be a different relationship with the idea of using drugs or alcohol. And it just relates to all the stories that I found when I asked clients, when was the first time you used? Like, how did this even come up? And they talk about, well, going to a hookup, or maybe they're going to a sex party and someone introduced it, right? And they offered it. And they didn't go out seeking it, but it was presented to them within the community. And that was the first time that they used. So it's just kind of more of a curiosity and exploration. And they found that they really, really enjoyed it. So what are the kind of the desired effects that they're seeking? Like in the research, they call it desired enhancements. This slide comes from a study that was looking at two qualitative interview studies. I was looking at or talking to participants across a range of gender and sexual identities who regularly combine sex with drugs. And the first one that they talked about, what they were seeking, was this emotional connectedness, right? That people felt capable of enhancing emotional connection and communication. And it eased the awkwardness around talking about sex, right? Or ease the awkwardness of talking about what is it they like about sex, which I think is more to the point. And here, many of the drugs that they were talking about was around MDMA or cannabis. Some talked about how they perceived it as like an artificial intimacy, but most of them really felt that it was authentic and it was meaningful for them. The second one was that they wanted to enhance or transform their bodily or affective experiences. Here, you can think of it like people wanted to like just turn up the volume on the pleasure that they were experiencing. Here, some of the drugs they were talking about was, again, MDMA or methadone, cocaine. Although they talked about how those drugs produced some sexual dysfunction, particularly with people with penises, but it didn't diminish the participants' overall experiences, right? They described it as just more sensual and more exploratory and less orgasm focused, right? The third one is that they were seeking that disinhibition and that sexual openness. Again, you're kind of hearing those themes of liberation, and what they were trying to liberate themselves was this negative self-talk or way they become distracted during sex. And they felt more willing to engage in sexual exploration when they were pairing sex with drugs. And then some of these folks also use language that sounded more therapeutic, right? That they saw it as having some reparative qualities. It helped them with that pleasurable exploration. But for some, they're like, the amphetamines really helped mitigate my ADHD symptoms, so I could focus and I could be present, right? It similar to how it helps them focus at work. It was helping me focus during sex. But they also talked about how they could overcome some disinhibition that was related to previous negative sexual experiences, right? So if someone has some type of sexual trauma, and some of those all the defenses that people have are typically avoidant defenses. So if they have avoidant defenses related to their sexual expression, they found that pairing sex with drugs is a way that they could move through that and not have that same avoidance be triggered. Now, it's not to say that people didn't talk about negative or difficult experiences. Some of them included things like sexual regret, or shame regarding their sexual encounter or their choices, right? They felt too disinhibited, but they weren't talking about it as necessarily like as a consent violation. It says they may have just gone a little further than they would have if they weren't high. Uh, some talk about how they felt like they were over relying on it, that it was too much of a crush, or the kind of the choices that they made, they wouldn't have made if they weren't high. And a lot of those negative experiences were from the participants who were engaging with sex with new partners, right? For those who were engaging in sex with previous partners or a long-term partner and they were pairing it with drugs, they were not having the same type of sexual regret or shame. And I think part of that's one is related to their mindset, right? That they likely were feeling more comfortable because this was someone that they knew, but they also had the kind of the scaffolding around, they know what the other person likes, they know their partner knows what they like, right? And so they were able to use this more as an enhancement, which was not as available to someone who was having sex with a new partner. And specifically with that lit review around chemsex, you can see some of the similar desired enhancements that they were reporting that they were seeking, right? From the decreased inhibitions, they were seeking that altered consciousness, that muscle relaxation that can improve performance, increase energy. Again, there was a phrase that I like that this research used when they were talking about esoteric acts, and I was like, oh, esoteric acts, what's that? But again, I was talking about fisting, so they really have a hard time with just saying fisting. I guess it doesn't get past the peer review censors. You can also see some of the other, I won't necessarily read this slide because I know we're getting close to time, but these are some of the desired enhancements that they were seeking. All right. I don't know if we're going to get through the remaining. I always cram too much. There's so much I want to talk about. So the last piece is around skills. So what are the skills I kind of want to highlight? Because obviously there's an infinite amount of things we can work on in therapy with these clients. But the skills that I'm looking for, and then kind of tailored some of these slides to, which will be focused on kind of more group interventions and kind of here and now intervention, things that we can do in the moment with our clients. So one, generally, is to be able to talk openly and honestly about their sexual interests and their disinterests, right? To communicate what turns them on, communicate what, be able to turn them off, because that's a lot of times it's where a lot of the shame lies, right? I want to help my clients make good decisions, right? And much of that is going to be around improving self-regulation. If you define self-regulation as how people either alter or change their feelings or prolong or amplify their feelings, right? They change or alter the negative ones, prolong or amplify the positive ones, or how they align their behavior with their values, right? This is all how they kind of regulate their behavior or assert some type of self-control. And we think about the central or the heart of sexual health conversations, it's about helping people manage sexual pleasure and safety, right? There's a tension between these two things that sometimes, so I want to help them make good decisions in these moments, right? So either improving the heat of the moment decisions or helping them reduce sexual regret or maintain a sense of integrity in these moments, right? When either they're altered because they're horny, or they're altered because they're high, or they're altered because they're high and horny. I mean, it can be kind of these difficult moments for folks. In general, I want to help them improve their distress tolerance and emotional regulation, right? Decouple shame from their sexual desire and their behavior, and use some of the techniques that people in recovery and recovery treatment programs talk about, like urge surfing or relying on external controls. And then lastly, I want to help them protect against negative consequences like STI, HIV, drug overdoses, unintended pregnancies. So I just wanted to highlight some of the interventions that are kind of moving in that space. And I'm a certified group psychotherapist, so much of my work is kind of with the lens of group therapy. So some of this can be applied to individual therapy, but I'm kind of highlighting this because I'm also promoting the use of groups in this space, because I think can be very important, because group therapy is such a powerful shame reduction intervention that I think this is a good use of that modality for folks who are struggling with this issue. So the first here are going to be around how to use the treatment frame, right? The treatment frame, how I view it, is the commitments and the expectations that everyone agrees to in order to participate in this group. It's fundamentally around timeliness and fees. To also, for my groups, is a commitment to honoring their sexual health plan, which is has a list of things that they are agreeing to not do, as well as making an agreement with everyone that they will disclose if they cross their boundaries at the next group, right? So already starting to create some controlled tension, and creating the opportunities for us to understand how they manage commitments and the defenses that then show up, right? Uh, for instance, the accountability commitment creates this opportunity to explore contradictions between, in a sober state, making these commitments. For one of my groups, it's you need to make the commitment around not using meth, but maybe not same with other drugs. So if they make a commitment around, let's say, not going on the apps, or making commitments like, I'm just going to drink on the weekends. Great. They did that in my office in a kind of a more sober state, and they crossed that boundary, right? Interesting. It's not about kicking them out, right? I just want to explore the contradiction between making this commitment and crossing this commitment. Or why did it take you, 3 sessions to disclose that this happened? What was competing with that commitment, right? All comes the opportunity to get curious, and to take a look at the defenses that show up, that get in the way of their commitments. And then kind of moving quickly, I want to make sure. Oh, I want to get to this next slide and then probably open up to questions. So this last piece, clarifying and evaluating sexual values. If you're familiar with research around self-regulation, Baumeister works in this space. He's a researcher and author. And what I like about what he produced is he looks at these ingredients of self-regulation. In some amount, these ingredients are present so people can effectively self-regulate. Standards, self-monitoring, willpower, and motivation. So the first one is standards, right? What are my clients' sexual values? Where do they fall on the spectrum of rigid to permissive, right? If they have rigid values, they may be setting themselves up with these expectations are really hard to achieve, right? So, and when they have this hard time to achieve them and they fall short, does that generate shame? So can we have an opportunity to evaluate and understand the impact of those sexual values all the way to the other side of permissive, right? They don't really have values around this. They're kind of moving into these sexual spaces without kind of thinking about what their standards are and what it is that they're trying to achieve that has its own set of consequences. But where I want to get to with this last one is trying to understand, or helping therapists think critically about how to evaluate standards. To not use what I consider an act-centered value system, where we're kind of the arbiters between what is good sex and bad sex, or healthy sexual behaviors and unhealthy sexual behaviors, that we help them think critically about the context, that we help them think critically about their motivations and the consequences. So it's more of an ethical framework when evaluating sexual behaviors, rather than an act-centered value system that says this sex act is healthy, this sex act is not healthy. That is more of an essentialist argument. The ethical framework that I invite people to consider is published in my book. These are a set of principles that are derived from a publication from the World Health Organization, the Pan American Health Organization, and a call to action around integrating sexual health into medical and mental health care. And they had this paragraph in there when talking about sexual behavior and responsibility and pleasure. And within that conversation, my colleague noticed some of these ideas that then became the foundation for this set of sexual health principles, right? You can start to see that this is more of an ethical framework rather than a list of what is good sex, what is healthy sex, what is not healthy sex, right? We want to help our clients and honor their autonomy and help them kind of figure out what is the type of sex that I'm looking for, and using some of these principles to help shape the conversation, right? Is it consensual? Is everyone consenting to be there? Is it non-exploitative? Like, are there people using power and control, or leveraging power and control to have sexual access to someone, or to have sexual gratification over someone else, right? It corrodes someone's ability to consent. Protect against STIs and unintended pregnancies, kind of the original definition of sexual health, right? The absence of some type of disease or unwanted unintended pregnancy. And the next before are helpful in discussions around also understanding what people are consenting to. And we've talked about this before around being open and honest with oneself about what they like and what they don't like, so they can be open and honest with their sexual partners about what they like and what they don't like, what their sexual history has been, what they envision for this relationship, which gets into the next one around shared values, right? Sex is a behavior and people infuse meaning into it, right? So it could be recreational, procreational, relational. Thank you. And are they having sex in the overlap, right? And then lastly, mutual pleasure. This is, I think, a principle that's unique to sexual health in the sense that definition of mental health, or maybe even spiritual health, physical health, we aren't necessarily highlighting or promoting the concept of pleasure or joy. I hope and wish we would in other areas, but so this might be an area in which people aren't as comfortable discussing or kind of considering that this is a part of health, is making sure that my pleasure is considered, your pleasure is considered, everyone who's in this sexual activity, their pleasure is being considered. All right, I just got the 5-minute sign, so I'm going to stop it here and open it up to if there's any questions in the chat. Everyone has the slide, so you can see what was left, which was this last slide around behavioral skills in group therapy. I'm going to come out of here. All right, Jade, I'm going to pass it over to you. Were there any questions that we saw here? I saw someone
We
ask
did
about.
have some questions earlier.
Yep.
Someone had requested what is poppers and what is MDMA, and I was able to send them some links in
Great.
regards to that information from I believe it was the NIH and the FDA
Thank you
to
for doing that.
explain what those were. The slides were not emailed, but I did attach them into the chat. They're further up, but I can also, once this presentation is over, I will send out the link to the slides to all of the participants who have registered. If you have anyone else who would like to receive the information, please have them use the link that I've put in the chat to put in their information so that I can have their email and they'll be able to get the presentation. So one of the questions we had is, how do you use this information for youth?
So that's a great question. I'm not sure what specific information, but I do teach on the sexual health principles as a way to help particularly adolescents to start to think critically about the sexual choices that they are making, to start to teach them about kind of sexual health and responsibility. The IMB model is an evidence-based treatment approach that can be used and applied depending on the type of health behavior change that you're trying to help facilitate with youth. I think that can be a helpful piece as well, trying to understand what the knowledge gaps are, what are the motivational interventions to use with youth, and skill building, right? I think that can also be applied in that direction.
All right. Does anyone else have any questions? In the meantime, while you all are putting your questions in the chat, we just wanted to say thank you. And Michael, we really appreciate you for taking your time out to present this delightful webinar about partnering sex with drugs. The University of Maryland and the University of Maryland Extension, thanks you all for being able to participate, and we will be sharing this information afterwards so that you all will be able to share it with your partners and network who are not able to attend. And Michael's information is here in the chat, so I will put that in there so that you all will be able to have that information as well. We will not be sending an evaluation for this presentation, but we are collecting data from the registration link so we know who our audience is for this presentation. So we definitely appreciate that. Unfortunately, this webinar will not be offering CEUs. There may be opportunities in the future for webinars to be able to provide that, but at the moment, we do not have any opportunities for that.
Everyone, thank you for being here. Really appreciated this opportunity. and have a wonderful rest of your day and be safe.
Yes, I am putting Michael's information in the chat as it is on the presentation slide. If you all have any additional questions or request any additional information, he has put his information there. Um, Michael, they're asking if you have any other opportunities to be able to present and share this information with other participants.
Please reach out. I don't have any trainings on this specific. Actually, that's not true. If you email me, I can tell you I'm gonna be probably putting this on a 2-hour version for another institution in May that's just was scheduled. So if you send it to me, I can forward that to you. And if you're interested in the topic around problem sexual behavior just in general, I'm currently team teaching a 9-month training program through the Sexual Health Alliance on problem sexual behavior, where we do a much deeper dive on this topic than just sex-related drug use. I can put that Sexual Health Alliance. If you Google them, you will find that larger training program.
I have also put in our website for Maryland ROPTA so that you all can see all of the programs that we offer as well as our email address. We do offer a lot of different programs such as the mental health first aid, which actually is a program to help train people to address people who are going through issues. A lot of them can be substance abuse issues as well. So if you're interested in any of those trainings, please feel free to send us an email or look at our website because some of them do directly relate to the information that was presented in this presentation. So we definitely appreciate Michael for being able to share this information and branching off of a lot of the work that we do. And we just want to say we have a lot of participants saying thank you very much. They thought this presentation was very interesting. So we would just like to finally thank you all for joining. We appreciate it and appreciate your questions. Both the Maryland ROPTA team as well as Michael's information has been put in the chat. I will be using all of the emails who were registered to be able to share not only the presentation slides, but the recording of the video once it's been edited. So thank you all again. Michael, we definitely really appreciate this. And if you all have requesting any further information, please feel free to reach out. Thanks again, and we hope to be able to offer a presentation like this in the future.
Bye,
Bye,
everybody.
everyone.